It's not something most cancer patients can do, but with oral cancer, patients can actually touch and feel and see part of the cancer. Good morning, I'm Jessica Lovell. Welcome to the Morning Medical Update. Today, we meet one woman who lost part of her tongue to help save her life. Yvonne Sieber was first diagnosed 6 years ago. Yvonne, Vonnie, as we are on Vonnie terms. How are you today?
Good.
So glad to have you here at the desk with us. We appreciate you coming in. We also have two of the doctors who are involved in your care, Vonnie.
Yes.
Dr. Kiran Kakarala is a head and neck surgeon who helped rebuild Vonnie's tongue, right? That's right. So you're going to help us kind of go into what details that entailed. And then we have Dr. Chris Leminska back with us today. He's a radiation oncologist who handled the radiation therapy for Vonnie's case. So, Vonnie, your cancer journey started with, you had just a sore on your tongue. I mean,
yes.
That can feel, I think we could all have, funky feelings on our tongues. We get canker sores and all sorts of that stuff. But that was back in 2017. So kind of walk us through the timeline of what happened. You first feel the sore and then what?
Yeah, actually during 2016 was the sore. My dentist sent me to an oral surgeon. He did a biopsy and said there was no cancer. And then in early 2017, it just hadn't gone away. He sent me to a local ENT. We live about 3 hours away in south central Kansas. And then he said it was cancerous, operated, but later said there was some cancer on the margins yet. He referred me to Dr. Kakarala. And like I said, we kind of checked out people we knew, did they know about him, and got really good messages to, he was the best
to
in
go
the
with
region.
This guy. I was going to say, did you get it? You did kind of your own second opinion research by asking around, and that is completely okay.
Yeah.
So you come here, but I want to go back because they said it was not cancer initially.
Right.
Docs, is that normal just to miss it altogether, the diagnosis?
Well, like you said, sores on the tongue are pretty common, and so the dentist is often the first line of defense here, or the primary care doctor, and they treat it like a sore on the tongue, which is not unreasonable, but these sores that don't go away are the ones we start to worry about.
So finally, we hear the word cancer. They think they have it. They didn't get all of it.
Right.
Does that happen? Docs, tell us about that.
Yes, it definitely does happen because sometimes we have a surgery done and we don't know that cancer is the diagnosis, and when you're doing a surgery for cancer, the surgery looks a lot different than if you're doing a surgery just to do a biopsy.
Gotcha. Okay, so Vonnie, you shared a picture of your tumor, and just a quick warning for viewers, if you're a bit squeamish, the image is a bit graphic. So Vonnie, tell us about when this picture was taken as far as your journey. When did this appear?
That was in 2019. I had the surgery, chemo radiation, and then for some reason it came externally on my neck. And that's when they recommended I go on immunotherapy.
So, Dr. Kakarala, just tell us what we were seeing, and is that typical with somebody with her diagnosis?
No, in fact, that was pretty far along the journey. After we had done actually 2 surgeries, chemo and radiation, that tumor had come back, and obviously we were very disappointed. We had thrown the kitchen sink at it, so to speak, and it had come back, and so immunotherapy was the next option.
And walk us through some PET scans that you've brought us, Dr. Kakarala, from different times throughout Vonnie's cancer journey. What are we seeing on the left and the right?
So I think we brought these PET scans just to show how tricky this disease can be. In 2017, she came in, and PET scans, you might know, they give you some sugar in your body, and the sugar likes to eat up that, the cancer likes to eat up that sugar, and it lights up red. And so anywhere you see red is potentially cancer. Of course, the brain eats up sugar, so you're seeing that at the top. But in the tongue, might be a little bit hard to see, but in 2017, there was some cancer left in the tongue, and we removed that. And then unfortunately in 2018, despite that surgery, it came back, so there's a little spot in the tongue, and that's when we had to do another surgery.
So tell us about Vonnie's reconstruction of her tongue. Well, what are we seeing here before we get to that?
Then next in 2019, we did a huge surgery followed by chemo and radiation, and you see that cancer just came roaring back, and that was the picture that Vonnie brought. It was not only in her tongue, but had started to come out through her neck. And the happy ending we have here is in 2022 and now 2023 we have Vonnie still with us, and you see in 2022 there's basically no red where there's not supposed to be red.
Nice. It is nice to see. I know you give the big thumbs up. It's nice to have her sitting here with us doing well, isn't it?
Absolutely.
It really is. So talk to us about that reconstruction surgery. Vonnie had told me about it. She showed us a picture of her wrist and how you made this all come together. Tell us about what you did.
So anytime we do a cancer surgery, the goal is to remove all the cancer cells, and unfortunately in her case that was removing a large part of her tongue. In the past we didn't have the ability to rebuild the tongue, and of course people had a lot of trouble speaking and eating after that, and so now over the last 20-30 years this reconstruction where we take a piece of tissue from the arm and transplant it, so it's like a transplant from your own body, and it allows us to rebuild that tongue and hook up little blood vessels into the neck, and over time that function is not, she'll tell you, not exactly how it used to be, but hopefully as close as we can get it.
Oh, yeah.
How is the function?
Quite well. People say they can understand me well. It swells sometimes. Right now it's a little swollen. I don't want to put my hand in there and push it down. But, and what I was so thankful, the way he did it, I still have my taste buds. So I can taste food very well. I can speak. I can sing now.
Good for you.
I'm very, very thankful.
I know you are. Why from the wrist? Why the arm? Why is that skin the best for this reconstruction?
Great question. It's actually, there are a few different options, and from the leg, from the arm, from the back, actually a few different options we can borrow that tissue from, and in Vonnie's case it just happened to be the best fit for what we were removing.
So you told us what's the same. Are there any differences, Vonnie, with your new tongue? Is there anything, I know you're so grateful and you don't really care what you can't do, you just care what you can do, but what is, other than the feeling, what's it like?
Well, it feels part of my tongue. It does swell some and gets, on occasion, gets, so I notice it's there. Like right now I kind of do. And for me it's a little harder to talk, but as long as people can understand, that's...
We hear you loud and clear. We like it. We like it.
Good.
So, Dr. Leminska, I want to bring you in here to talk about the photon therapy that Vonnie went through. When did that come after the reconstruction?
So the photon therapy came after Vonnie's second surgery that Dr. Tacarella was describing with the reconstruction, yes. So that was what we call adjuvant therapy. So we knew she'd had aggressive disease. We wanted to reduce her recurrence risk as low as possible. And so she underwent a 6-week course, 30 radiation treatments to do that.
And Vonnie, you brought a photo of you going through the photon therapy. What was that like for you? Explain to folks at home.
Well, thankfully, I got a lot of guidance and support. I'm a little claustrophobic. I was worried about that mask that had to go over my head.
That darn mask again everyone talks about with the photon and proton.
Yeah, going into the machine. But one thing I started doing was, and Dr. Leminska helped me know that, this is, I need it. It's, and when I was in the machine, I actually started praying while I was there. And we also had a grandson who passed away about 4 years before this. And I prayed and talked with him about what he'd gone through mentally. And I ended up being very relaxed in that machine after a while. And it was kind of a peaceful time.
That must have, I was going to say, that must have been a really powerful moment. Tell me about your grandson, because I know you had said that he had passed away from a similar diagnosis.
He was in St. Louis Children's for a year of leukemia. And then in the end, all the things they tried, he passed away at age 11. And
living life for him, I bet.
Yeah, right. That's a good way to say it.
Dr. Leminska, why photon for Vonnie? And help folks understand what photon is. We talk a lot about proton. Tell people what photon is and why it was so good in this case.
So photon therapy still is our sort of bread and butter in radiation oncology. It's the type of treatment that most patients undergo. We use it in the mouth, especially in postoperative patients, for a couple of reasons. The tongue is a mobile structure. And photon therapy, high energy X-rays are better at handling the motion and variability there. There are also, for someone like Vonnie, timing issues. So after a big surgery, it's important to start treatment in a timely fashion afterwards, and photons are faster to ramp up than protons. So those were factors that came into play.
But when you're handling an area near the head and you want it to be very precise, how do you keep it and limit it from damaging any other areas?
So some of that is the setup process that we were describing. It's the mask, it's other physical devices that we use. Some of that is stuff that happens on the planning side. And so I think one of the themes for today is kind of teamwork, whether it's going from the dentist to the head and neck surgeon to radiation oncology and immunotherapy, and teamwork's part of my department too, so I work very carefully with physicists and dosimetrists. We do 3D virtual planning on all patients to make sure that we've checked, quality controlled, allowed for any setup or anatomical variability.
And this went on for 6 weeks?
So she underwent 6 weeks of therapy, yes.
And Vonnie, you were ready to have that behind you?
Yeah.
What'd you do with the mask afterwards?
I still have it in storage. I don't know why I can't get rid of it.
No
but
one ever does. I think it's like this badge of honor, so
Yeah,
to speak.
I
You
guess
keep it to
so.
say no more. This
Yeah.
thing, people put it on the wall. People have made art out of it. It's just
I haven't done that, but I should do that.
okay. You send me a photo of that. I want to see what you can do. So immunotherapy. When did the immunotherapy come into play?
When that external happened in summer of 2019, immunotherapy was, I guess, the last choice, last option. And they told me I had about a 20% chance, given my situation at the time, of it working. So it started helping. We could tell it was helping in about a month, and then I was on that till 2020, and then I had a small lump here, and so he changed the immunotherapy and some chemo, and then I was on that. So 3 years total until last October.
And tell us more about the immunotherapy process and why, again, a really good option for her in this case.
So in Vonnie's case, she went through our traditional treatment, surgery, radiation, chemotherapy, and this cancer unfortunately laughed in their face. It came back, that picture she showed. And Dr. Napani's the other member of our team we don't have here. He's our medical oncologist, and immunotherapy has really given him a tool that we didn't have in the past to give patients like Vonnie hope. Like she said, it's unfortunately not effective for everyone, but it's changed the conversation that Dr. Leminska and I and Dr. Napani have with patients like her. When the cancer comes back, it's offered hope.
And you were so quick to say, we've got to get Vonnie on the program and talk about her case. And I take it she was a really good patient. Yeah, you were. You were. And it's so nice to have you sitting here with us doing well. If you have any questions for anyone sitting here with us today, just be sure to send those in the chat on YouTube or Facebook. You can tweet us or email us at the Medical News Network. The info is right there on your screen. Let's get a quick COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning. How are you?
Hi, good.
Hey.
Yeah, our numbers continuing to trend in the right direction. 33 total, but 14 active infections, only 1 in the ICU, which is a lot better. We had up to 5 or 6, I think, about a week ago. So.
All right, so you cover all kinds of infectious diseases.
Yeah.
There's a new CDC update on poliovirus that I want to ask you about, specifically vaccine-derived polio outbreaks.
Yeah.
What are those, and where are we with that? Tell us what this all means.
So in general, there is wild polio type, for which most people have gotten vaccinated for, in that vaccination program since the vaccine was introduced was issued to help reduce and eliminate wild polio virus. Now, sometimes the polio virus can revert from the vaccine in very, very few instances and cause what we call vaccine-derived polio virus and cause poliomyelitis that way. The vast majority of cases around the world have tended to be the vaccine derived. But we also have a vaccine that we can go, a separate, different polio vaccine that we can use to help treat that and immunize people to protect against that as well. So there are wild poliovirus and vaccine-derived poliovirus as well. The vast majority around the world continue to be the vaccine-derived, but as we have gotten through the pandemic and had a decrease in polio vaccine programs around the world, we've seen a little bit more of the wild as well. But again, the vast majority tend to be the vaccine-derived. And the easy answer to that is please just get up to date with your polio vaccine. You know, in the United States, we use the inactivated poliovirus, which is an injection. It's a shot. It does protect you against all of these as well. And so that's the easy answer to do. So if you are not up to date or your children haven't been vaccinated, please get them vaccinated and get up to date with your polio vaccination as well.
So yesterday, our faithful viewer, Ruth Ellen, had a question. I promised her I would ask it to you today. She wants to know, after having COVID, how accurate are those at-home COVID tests? And how long do you need to wait to take a COVID test? If you've already had it, how accurate are they?
Yeah, I mean, you know, the home tests are testing the antigen, so just kind of pieces of the virus themselves. If you've had COVID in the past, you can certainly, if you think you are reinfected and it's been some time since you've had that initial infection, you can use that test to test for acute infection at this point in time. The best data that we have is that those at-home tests, even with the current variants, are probably about 70 to 75% sensitive for picking up the disease, and that's up to 3 to 4 days after symptom onset. So there was a lot in that question, I understand that, but the home tests are tending to be accurate. You may need to test 1 or 2 days sequentially to get an accurate answer. But if you've had COVID in the past, you can certainly, if you think you have a new infection, you can certainly use that home test to retest as well.
Any reporters with us today? Let's get to our community questions. At Ruth Ellen, already in this morning. She wants to know, did you get to listen to music while you were doing your photon, the way they do with Proton? Is it the same type of operation, Dr. Leminska? Do people get to do that?
There are options to listen to music.
Did you get to do
we
that?
have different requests. Depends
Bonnie,
on the
did you
patient.
listen to
I
music?
ended up more kind of just centering my mind and praying.
Good. Okay, good,
And
good.
so I didn't, but I would have liked that too.
Okay, you
but
can
I
rock
didn't.
out to some music. People always want to know, because we talk so much about Proton and Photon, just like, what's it like in there? So what are the major risks of oral cancers? Are there any risks that people should be looking out for?
So I think risk factors for oral cancer, you know, there are the classic things that most of your doctors will tell you, you know, don't smoke, don't chew tobacco, don't drink alcohol, especially hard alcohol to excess. But we also see these cancers in patients without those risk factors. And for that, screening. And screening with your dentist is the front line of defense.
Okay, that was my next question from Evelyn. Is there any screening for throat cancer or oral cancers the way there are for colon or breast cancer? Tell me about that. And are there questions that we should be asking our dentist?
As of now, there's no blood test that can test for oral cancer. And so, like Dr. Leminska said, visiting your dentist on a regular basis, that's a good idea just for your teeth, but it turns out they're actually, like we mentioned earlier, the first line of defense and often find these cancers and refer them to us. And then your primary care doctor is also a really good place to get that screening.
Yeah, when you're at the dentist, like while you're in there, check me out. Really check me out. Make sure that I'm doing good in there. Question about, is a sore that doesn't heal, and maybe for how long, is that a good clue to get it looked at? What should people do if it's just been around, what, a week, 2 weeks, a month? How do they know to come find you?
In general, cold sores we talk about that maybe are caused by a virus go away within a week or two. So yeah, a sore that lasts for more than a week or two, I would say is a good thing to get checked out. It turns out that not all sores, luckily, are going to turn out to be head and neck cancer, but sometimes the only way to figure it out is to visit with a doctor.
Know your body and ask lots of questions. Sky wants to know, is an enlarged lymph node a common way for throat cancer or oral cancer to be detected?
So probably the most common presentation we see, actually, at least in my world, is an enlarged lymph node. Often it's a man who notices it while shaving and ignores it for a month or so until his wife or partner makes him come in. But yes, similar to a sore on the tongue, I mean, we can all have little lumps or bumps in our neck associated with a cold or sinus infection or something like that, but something that lasts more than a week or two, doesn't go away, absolutely that should be assessed.
Yan Liang wants to know, and in Bonnie's case, you were able to save her taste buds, but how do you do that? How do some people lose their taste buds? How do you help avoid that during this type of surgery?
It turns out that the arm doesn't have any taste buds, and so the key for her was trying to save as much of the normal tongue as we could, and in her case, luckily, yes, we were able to save a significant portion of her tongue. Some patients, unfortunately, that's not possible, and they do lose taste.
Okay. Question about HPV. We hear a lot about oral and throat cancers related to HPV. Help us make the connection, if there is one. Dr. Leminska?
So oral cancers are not classically linked to HPV or human papillomavirus. They, as I said, are commonly linked with smoking, drinking, or sometimes in patients who don't really have any of those risk factors. Obviously, one of the things that's important to us in the cancer world is prevention, and HPV and the HPV vaccine are important for prevention of cancers that are a little further back in the throat. So oral cancers are the lips, the tongue, the roof of the mouth. The tonsils and the base of the tongue are a venue for HPV-associated cancers, and those can be prevented with the vaccine.
Jen is asking Bonnie, how did you handle all this treatment while also living 3 hours away? You actually came up today for some treatment, so we're glad you got to stop by here first, but that's a lot of travel.
Yes, my husband is a gem, and he's been with me every step, and we drive together, and sometimes we even have fun while we're up here.
You might as well. You might as well. He's actually just over here,
Yep,
yonder,
he
in our
is.
control room. So what's his name? Let's give a little shout out.
Jerry.
Jerry. Jerry, where are you, Jerry? Can we see you? He's hiding, but he's back there telling the guys how to work it. So what, a question from Erica was just, first of all, is there any family history that you know of, just of cancer, throat cancer? Did this come completely out of the blue?
Yes, out of the blue. And I didn't smoke.
You want to put that out there.
I
You did not smoke.
Some of my friends did. They keep saying, you shouldn't have gotten that. But anyhow, now it's there. Yeah, I don't know how I got off on that, but yes.
Well, no. Well, that would be the next question from another one of our viewers is how common is this? Certainly, how common is it in general, but for someone who didn't have any of those risk factors?
It's certainly much, much more common to have a cancer like this in someone who smoked or chewed tobacco. But like Dr. Leminska said, we see a fair number of them here, especially as a referral center. But if you look at statistics, this would be fairly rare.
And again, makes it tricky because there's no real screening process about that. What's the what's the best thing that has happened because of this, Bonnie? Is there any bright spot?
Oh, yeah. I think I'm more grateful for every day than maybe I would have been. I don't take it for granted. Family, friends, grandkids, I love it. Love being able to get up and be with them. So I'm pretty happy.
Yes, you are. Yes, you are. I want to get our takeaways today. And Dr. Leminska, what do you want folks to take away from our conversation today? What's the big important point we want to drive home?
I think the important take home is just kind of the journey of cancer patients. So Bonnie's journey, started with screening and seeing her dentist. As she went through treatment, it was important that we continued to check on her, and that, as you can tell from her story, we kept having to intervene, and then finally we had an intervention that seems to have done the trick. So I think it's that teamwork and that continuum of care.
Question from someone, Dr. Caccarella. Will you continue to see Bonnie? What will her follow-up be?
Usually a patient with head and neck cancer, we follow for at least 5 years, and most of my patients, I tell them I'd like to see them for the rest of their life.
I figured.
Because unfortunately there is a risk that it would come back. In Bonnie's case, we're not going to talk about that because I don't think it's going to happen, but we'd love to see her for the rest of her life. The other reason is the side effects from her treatment are with her for the rest of her life, and so it really is important to follow up to make sure we're managing those.
Right. You kind of hope for it to be we always call it, we like it when patients are boring. They bring in no problems, nothing's come back. You're just coming up for a fun visit with friends, right? When you come here, that's what we want to see. What's the takeaway today?
I would echo everything Dr. Leminska said. The other thing I would point out is that patients like Vani traveling 3 hours to see us, we think hopefully we got a good outcome because of that teamwork that we were able to bring to the table. This is a comprehensive cancer center, and having the surgeon, she came to see the surgeon, but I brought in my friends, the medical and radiation oncologists, and it turned out we actually really needed all three of us, and of course keeping Vani at the center of that and involving her in every decision along the way.
So Vani, what do you want folks to take away from your story?
I think for me, the support system of family and friends and our church community, faith, all of that has been unbelievable. And sister and friend who were nurses came and helped after surgery to take care. We had a lot. And I realized not everyone has a support system. But I encourage them to use the services at the Cancer Center and do what they can to not go through it alone.
Yeah.
And let people know they need them. Also, I was told that I'm pretty compliant, and I did whatever they told me to do very carefully. And I think the personal responsibility of doing what we're asked to do to follow up helps. And then I am very appreciative of the team. And Dr. Nupani isn't here. I see him a lot with the immunotherapy. But the way they work together, and the way I think the KU, my sense is the physicians are always looking at what's out there and what's new and bringing it to the care. And I really trust them.
You got to be your own advocate, right?
Yeah.
And do your research like you did on this guy.
Yeah.
And found us. We're so glad you did.
Yeah.
All right. Today's takeaway from Dr. Hawkinson, what you got?
Yeah, I think it's pretty easy in talking about what Dr. Leminska had talked about. You know, vaccination, be up to date with your vaccines. You can prevent a lot of morbidity and mortality, that's illness and death, but also you can prevent things like cancer. So if you are not up to date on your vaccines, if your children are not up to date, please get them up to date. The vaccines are very safe and very beneficial for many, many reasons.
All right. Well, thank you to all of our guests today, and thank you to our viewers as always. Great questions, great conversation, and we will see you back here tomorrow for Open Mics with Dr. Stites. You've heard of a blood bank, but what about a stool bank? I'm Jessica Lovell on the next Open Mics with Dr. Stites. Fecal transplants. While it might sound strange and even kind of gross, fecal transplants are saving lives. Who qualifies and why? Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.